So I just wanted to start by echoing some of Dr. Tepperman's comments. I think that this is entirely a uniquely American problem. I'm Canadian, and when I first moved to Chicago, where I did my training, it was the first time in my life, thank you, it was the first time in my life that I had to treat babies who were injured by guns. I still remember the first case that we saw in Chicago. In pediatric trauma, you bring the parents into the trauma bay with you. It was a 6-month-old baby, shot in the chest and the abdomen, blood everywhere. And the parents were just on the floor, distraught, as you can imagine. And I've never seen anything like that in my life in Canada. And I saw it week after week in Chicago. And it does not have to be this way. It does not. So I'm really honored to be here today, to be surrounded by such inspirational individuals who are all here for one common goal: gun violence prevention. So I think this is a very exciting panel today. Our focus is on mobilizing the system for change. We're joined by 2 health system leaders who we're very fortunate to have. So we'll start off by just saying, can you please introduce yourself, both of you, and tell us why gun violence prevention is important to you?
So thank you for the invitation to be here. I'm really thrilled to be here. I'm Mette. I am a pulmonary critical care physician, and I transitioned from being a practitioner to a chief clinical officer to now a CEO of a university health system in Arkansas. And I'm here because of our organization's pledge, which is ensconced in its mission and its strategic plan, and that is to improve the health and the welfare of Arkansans. We have a huge gun violence problem in Arkansas, in the top 10 states with gun violence, related deaths, and so it is our problem.
And I'm Masiakos, I'm the substitute. And a little bit of a disclosure, it took an event like this in New York to get a bunch of people who I've interacted with online for the last 2 years for me to meet people. And that says volumes about what we need to do to move this needle. I'm the pediatric trauma director at MGH. And over the last year, I was assigned to be one of the co-directors of the Gun Violence Prevention Center by my CEO and president. And it's motivated me to be a little bit more thoughtful about my approach. Many of you may know I'm a provocateur. And I'm not going to hide that today. I think Dr. Tepperman is more of a provocateur than I am, so I have competition now. But I think my New York roots, being born in Astoria, has made me the kind of person that I am in the streets.
Excellent, thank you. So, first question, what are some key approaches that the health system as a whole can take to address this issue? We've already talked about research, advocacy, other interventions, but what do you think is the most critical thing that the health system should do, and have you seen any pushback or internal debate thus far?
So maybe I'll make a commentary first that, of course, when we talk about the health system, we better define what that is. Do we have one entity that we can call the health system? I would argue that everybody in the room is part of the health system. But if we're talking about my unique entity and where it fits in a state, there are a number of things that we can do. Certainly the 3 that you mentioned, I would submit that the 4 entities, the 4 buckets already described, one does not have primacy over the other. If we don't do all in concert, we're going to fail. I'm a strong believer that we need more data, more evidence. We have to do this in an evidence-based approach, but evidence data takes a long time to accumulate, and we cannot not intervene on the things that are sort of obvious in front of us. When I have this discussion about gun violence in my community, Little Rock, Arkansas, which is a rural dot in a urban dot in a very rural state, and talk to members of the community and talk to them about gun violence, they really want to talk about what are you going to do to help fix all the other problems in our community. They recognize gun violence as a symptom, a sad symptom, something they have to deal with all the time, but it's not, they identify as one of the root causes. And if we as a health system don't fundamentally do something to address those issues, we will fail at just removing the vector.
And I think it's important for us to understand how to talk about it as a healthcare system. I think the nomenclature is there, but the way to do it is not there. And one of the things that I'll allude to is how we got to the point of having a gun violence prevention center at Mass General Hospital where 100 years of tradition is impeded by progress. We met in a room, Hannah Sachs and I met in a room about 4 years ago. Her cousin was killed at Sandy Hook. And Hannah and I sat down, and my experience is like Chethan's experience. We talked to the mothers about the dead kids, and it was enough for me to say I don't need to do this anymore without doing something about it. So the two of us met in a room on Thanksgiving about a year after the Sandy Hook event, and the 2 became 4, and the 4 became 8, and then we formed the Gun Violence Prevention Coalition, where we had standing room only in a room on a Friday, once a month on a Friday. And we went to Peter Slavin and asked him to support us in some way, and I took the Shawshank Redemption approach, where I would go every week to talk to him about supporting us in some way, and eventually he coughed up some money, and we formed the program. So what do you do with a program in a hospital, but try to understand where the sentiment of the hospital lies with its providers and its patients? And what we quickly found out is we don't have a conversation about guns at all, partly because we don't know how to. We have this is our lane phenomenon that happened about a year and a half ago. But what are the next 10 words to this is our lane? The idea is to understand where we are as a baseline, and then go on and talk about it. I'll just give you a little bit of a study that we did in our emergency room that was published. We looked at kids who came to our emergency department with homicidal or suicidal ideation. And we looked at 1 year of that diagnosis. 18 years or under, there were 100 kids that came in. And only 25 were asked the question of access to lethal means. So the discussion of what we're doing as educators of the public, of our own residents, fell short. And so we embarked on an educational experience that I'll touch on a little bit if we have some time.
Yeah, please.
For the first year, as part of our funding, we went to the program directors of the medical and surgical residency programs and said, can we spend at least an hour during their didactics to teach them about how to talk to their patients? And they bought in, and then others heard about it. The OBGYNs bought in, and the psychiatrists bought in. And we had a commitment from all of the residency directors to do 1 hour of didactic teaching during their entry to the residency program. There's no better place to get a bunch of residents together to do something than in July. So before we started, we got a residency director and a resident in a room with pizza from all of the disciplines, and they came up with scenarios of what it would be like to talk to their patients about gun violence. The psychiatrists said they would do it in 30 minutes. The surgeons wanted to do it within the time it takes to do an abdominal exam. But it's so much fun to watch 2 residents from 2 diverse programs come up with a scenario. And we simmed 142 residents last July. We hired a boatload of actors, and we spent an hour with them. And now we're looking at the details about whether we had an effect. That's how you change the culture in a medical center.
Wow. So something that comes to mind, though, is how do you really connect with everybody in the system, CEOs, stakeholders, caregivers, especially when you might have different populations that you're dealing with? And I'll use the example here. I mean, Dr. Mette, you're from Arkansas. So can you comment on different perceptions about gun control in your own state and some difficulties that you might have had pushing the same type of initiatives that Dr. Masiakos is talking about through?
Right, so Arkansas almost certainly has to be one of the states with the highest degree of gun ownership, over 85% of the populace, the general populace. That must push near 100% of adults own guns. It is, as already stated somebody else earlier, that there's owning a hunting gun hunting rifle is a cultural norm in Arkansas. And any attempt to dissuade an individual, a family, a town, a culture, that should not be the case is a non-starter. By the same token, in my discussions and groups of gun owners in Arkansas also believe very much in responsible and safe gun ownership. So there's common ground that's already built into the culture. So the issue is not about eliminating the vector. It is making sure that we contain it, to make sure that there is a competent, responsible approach to gun ownership. And where there has to be some removing of the vector, those firearms that don't belong in the hunting culture, for instance, ought not to be legal. I don't know the data on this, but in the circles that I have these discussions with, there is very little dissension from the fact that military assault rifles are not part of the armamentarium that belongs in the hunting culture, and probably not in the overall population in Arkansas. So one other point, I'm not sure that the NRA has the sway that many of us fear that they have. In Arkansas, threatening to take somebody's gun away is the same thing as taking somebody's right to drive a car. It's not a gun issue, it's an infringement on their personal rights. So taking the discussion out of that context and talking about responsibility, celebrating what has been rich for them, but making sure that we eliminate the possibility of injury.
So to that point, Dr. Masiakos, despite all our discussion about research and science, which I think is incredibly important, many gun right advocates obviously are very entrenched in the idea that guns don't kill people, people kill people. And despite science and research, they might not be receptive to changing their minds. So how do you reach out and work with those individuals? And is there a point to try?
I think there's a point to try everything. I think that, again, we have to change the conversation. I think these folks are our lifelong patients. And I go back to Dr. Tepperman's observation about closing his eyes and seeing an army of people of color who are young men who don't walk or don't use their arms anymore because of spinal cord injuries. There are lifelong patients. And if you approach this like any other disease, HIV was brought up today, cholera if you want to go back a few years, but if you talk about it with your patients in the same way, I think it impacts them. I'll tell you, I live in a blue state now. I mean, a pretty blue state, I suspect. One of the things that we're talking about today that seems to be coming back all the time whenever I attend one of these sessions is the number of deaths, And we talked about the number of injuries, but we really don't know the number of injuries. You go to the communities of color in Boston where they hear 2 gunshots a day that maybe don't even hit somebody. That's impactful. And if you have these conversations with your patients, you're not talking about guns killing people or people killing people. It's the fact that the gunshots are going off that may not be killing people, but socially and psychologically and these are impactful events. So I think if you turn the discussion to those things, it may be more impactful than talking about the dead neighbor or the dead child. And it's an educational thing. When we started talking about it at Mass General, nobody wanted to talk about it. And that was 5 or 6 years ago. And I'll put up a slide. We invited people to come out to the courtyard during the March for Our Lives event. And this was lunchtime on a busy Tuesday or Wednesday in March. And we thought a handful of people would show up. And a boatload of people showed up. And Peter Slavin's window is up in the left-hand corner. And this was the event that inspired him to act. It was apparent that people wanted to do this. And no different than what the general population feels about assault weapons bans and background checks. So the discussion has to be had, and we can't be afraid of having the discussion.
So Dr. Mette, do you, in your health system, do you guys have that discussion?
We do. So we have put into our EHR, our EPIC, questions that get asked, and we audit how those questions are, or at least the documentation of the answers, the responses in our EHR. All those social determinant of health questions, including gun ownership and, importantly, gun safety measures, locking up of firearms. So we have those discussions with the patients. We have discussion within our organization and within the community, but not nearly enough. We're going to run out of time shortly, so I wanted to state this to Michael, that as a representative of a healthcare organization, that UAMS is ready to sign the call to action, ready to sign today. But here's a provocation to you, and perhaps a friendly amendment that it doesn't quite go far enough. And my request to you and those in the audience is consideration of adding Michael to the list. And I might add robust approach to building resilient, healthy communities where the substrate that allows the vector to take hold must be addressed. And then another comment about we have a national epidemic of violence. So it's not just gun violence. And without addressing that substrate, we may fail. But I'll go out on another limb, and this will probably create a lot of problems for me. There is no room for assault-style rifles, and that we must implore our legislators to make sure that there is a federal ban. I would request that be a line item.
So Dr. Mette, I mean, a lot of physicians have spoken, caregivers have spoken. You know, you're one of the first executives to speak. So how can you uniquely contribute then to this, initiative that we've all been trying to deal with over the years? What can you do specifically?
Yeah, so fortunately or unfortunately, a CEO does have both the exposure, but also the ability to influence. So my organization has a really great legislative liaison. We have a direct route to the Arkansas State Legislature and to the governor. We have influence there. We have influence with our federal legislators. It would be remiss of me not to exercise that prerogative to make sure that we engage with them. That is fundamental and first. The second is that, Michael, here's the other provocation, everybody in the room. The only hesitation we were having about signing on, the bottom line here is we don't want this to be a movement that fades. So making sure that we continue to work on this. This is going to require resiliency on our part and never to stop the movement.
And I can't leave without saying this to the CEOs and the presidents of these health or care organizations. Pony up. Let's get some funding out there to the places that we need to fund to get the research started before we start thinking about where the funding is going to come from the government. Let's do what Peter Slavin did. I went and I asked, and I have a funded gun center. I think this is the pivot point that we have to think about at this time.
Perfect. Thank you very much.